Today we're going to have a lecture by Dr. Rooke from Mayo Clinic. He's a professor of medicine, very well published with interest in erythromyalgia and varicose veins and many other aspects of vascular disease. And we look forward to your talk, Dr. Rooke.
All right. Can you hear me on this right now?
Yes, we can.
Well, this might be the other option, is I may just go to speakerphone here, if that works for you, and I'm going to try this. So you feel free to just stop me if there's any problems at any point here, because again, I'll just tell you, I'm sort of new to the webinar business. I'm old. I don't do technology really well, so I'm a little bit intimidated by it, and this is a little new to me. I'm also used to seeing my audiences face to face, so this will be a little bit of an issue for me as we time things and go through things here. Well, what's that?
We're all attentive, and we will save the questions for the end. And
sounds perfect. All right, well, I'm going to move ahead here. We're going to be talking, as you can see, about unusual vascular problems today. I've got two things that I want to disclose right off the bat. And the first is that I have nothing to disclose. But the second is I want people to understand that even though, this is a radiology-sponsored event tonight, I'm a card-carrying cardiologist. That's how I did my training. That's where I got my background. But I'm completely non-invasive, so don't think of me as an invasive person. And in terms of cardiology, I limit my practice entirely to vascular disease. One of my real specialties and kind of areas of interest is in the odd or the rare or the orphan diseases. And when you ask the question about, why are we even bothering to talk tonight about something like unusual vascular problems, there's a couple of answers. The first is that it's a fun topic. There's nothing better for sort of an audio-visual presentation like this than unusual vascular problems. But the other thing is that it illustrates, I think, some of the shortcomings of evidence-based medicine, which we've got to keep in the back of our mind. Evidence-based medicine has become such a big concept in the last decade that it's really gotten a little bit out of hand. We've reached a point where people are afraid sometimes to do things because they can't turn around and point to some source in the literature and say, well, here's the evidence for why I'm doing this. One of the things about unusual vascular diseases is that because they're unusual, there's very often no evidence about what you're going to do. So you've really got to be thinking about how you make decisions when you don't actually have data or evidence or know exactly what it is you ought to be doing. Now, to organize a talk like this, I've used one of my kind of classic techniques, the rule of fours. 4 is a magic number when it comes to a lot of things. The Greeks had 4 seasons. There's, the 4 humors. Oh my gosh, cartoon characters always come armed with 4 fingers because they're easier to draw. The greatest car of all time, the 58 MGA, had a 4-cylinder engine. 4 is kind of a magic number. And that's how I've chosen to organize this talk, is around a 4-square approach here. I've made a 2x2 box for you. And on the one axis here, we're going to look at disease incidence. On the other, we'll look at the way the disease presents. And a disease can either be a common or an uncommon disease in terms of its incidence. Diseases, regardless of whether they're common or uncommon, can also present in a usual or an unusual way. They can present in the common or uncommon manner. So by constructing it this way, we can have common diseases that present in common ways, uncommon diseases that present in common ways, etc., etc. Now, we'll start up here in the top left-hand corner, And I'm going to start up here really only to dismiss this, because this is not what tonight's talk is about, the common presentation of common diseases. You know, there's a lot of things out there that you guys are already experts at, regardless of almost whatever stage you're at. Atherosclerosis, for example, the stuff that affects hearts and carotid arteries and aortas here, is common. And even in my, sort of weird practice, it accounts for probably 90% of all the arterial diseases that I see. So you guys know what atherosclerosis is, and you all know what to do about it. The same thing is true with this entity here. It's kind of fun if we're in a face-to-face situation, because, I'll ask the audience, do you know what this is? But you guys are looking at this right now. You know exactly what this is. This is fibromuscular dysplasia. And FMD, it's interesting because traditionally we think of it as being something that we see in maybe 1 to 5% of people. That number has traditionally come from renal donor series and autopsy series, but now that imaging is getting so much better and is being applied so much more, the incidence of this is probably even higher than we think. So we've got some registry studies that are going on in the vascular medical world right now that are looking at registering patients with fibromuscular dysplasia. We're trying to answer all kinds of questions about it, including how common it is. But for the time being, I think, subclinical cases really count as sort of a common entity, as do the clinical cases. And more importantly, you all know what to do about it, in the radiology world. You stick a balloon in there, you inflate it, you don't need no stinking stent, you don't have to operate this stuff, you just break those webs and stretch that vessel, and things do well. Here's another example of a disease that is common, something that you all recognize, even though this particular example is a little unusual. I had a 70-year-old man walk into my office and sit down with his records a short while back. They were in his lap. He'd been referred here, and as I looked at this pile of films and papers on his lap, I could see them rising and falling with each heartbeat. When he stood up, what I thought was a potbelly here, or what actually, looked like maybe a 30-week pregnancy, turned out to be the biggest abdominal aortic aneurysm I'd ever seen, a 17-centimeter one in cross-section. Aneurysms, abdominal aortic aneurysm, AAAs, things like that. These are common enough that they don't really qualify as unusual or uncommon diseases, even though one this big might be. But mostly they're common because you know what they are when you see them, and basically you know what to do about them. Now the same thing exists over on the venous side of things. Things like deep venous thrombosis and stasis dermatitis and venous ulcerations and varicose veins. You guys are familiar with all of these things. And just like atherosclerosis accounts for 90% of the arterial stuff, these kind of venous problems account for about 90% of the venous abnormalities that I see. So they're the common ones, the ones we're not going to discuss tonight. There's a few other things that you don't think about all the time that are also common if you look at them statistically. Here's one. Young girl comes in. She's in her mid-20s. She says that for the past 5 to 10 years she's been noticing increasing prominent veins in her inguinal region here. And, cutting to the quick here, when you do an angiogram, a venogram of some type, you can see that her iliac vein over here on the left is being compressed by the right iliac artery. And those veins in her inguinal region are collateral veins that are forming up around this. This is, of course, May-Turner syndrome, something that is very common, something that we all should be recognizing, and we all know what to do with it when you see it. If it's really bad, if it's caused clotting, you get the clot out of there, and now, we used to have to try to operate these. It was hellacious. Nowadays, we can stent them with good results. And again, I'm bringing colds to Newcastle. If you think I'm going to, non-interventional me is going to tell you folks anything about how to do that. So with that little background, those are the things that I'm not going to talk about. Now, what are we going to talk about tonight? Well, we'll start with the first category over here, the uncommon diseases that sort of present in the usual way, common presentations of uncommon diseases. And in my practice, that's the most prevalent, the most common of the unusual diseases. It probably accounts to about 5 to 10% of the various oddities that I see. The big question that you need to be asking yourself when you see cases like this is, what is it? If you can figure out what it is, you're going to be able to figure out what to do about it in the vast majority of cases. Let's look at this. Here's somebody who's got these funky-looking saccular aneurysms hanging off their thoracic aorta and the same lesions down here in the abdominal aorta. What the heck is this? If you can figure out what it is, you've got half the battle going as to what you're going to do about it. These are mycotic aneurysms. And just as a little side note, when you see a mycotic aneurysm of the aorta, by far, the most common causative agent here is going to be salmonella. I don't know why, but that's a truism that's probably been valid for the last 50 years. Salmonella has a propensity to do this stuff. Here's another unusual shadow that reflects an aneurysm, in this case a thoracic aneurysm. What if I told you that this aneurysm belonged to this guy here? If you can figure out who the guy is, you probably have a pretty good idea of figuring out what the etiology of this aneurysm is. Yes, very good, Heath. I didn't realize we could type in like this, but that's fantastic. Sure, this is syphilis. And, Al Capone was one of the very first people in the civilian world back in the late 1940s to actually get penicillin in the post-war period for his, at that time, tertiary syphilis. It wasn't enough. He still expired from it. Incidentally, just as a side note, Al Capone never made it past the 6th grade, and yet at the time that he died, the U.S. government estimated that his net worth was something like $100 million. Is there a take-home message to this? You bet there is. Income, kids, is not proportional to the length of fellowship training, so always keep that in mind there. All right, well, you guys are going to have a long night ahead of you here, I can see. I'll show you a little more of what you're in for. Here's a 70-year-old man who has sudden vision loss. If I was sitting here with you, looking you eye to eye, I'd be asking you, well, could anybody look at this guy with his gigantic bulging temporal arteries and tell me why he has sudden vision loss? And the brightest among you would look at me and say, well, he's got temporal arteritis. I don't know. In this particular case, that's not why he has a sudden vision loss. He has it because I put this black thing over his eyes so you can't identify him. But in fact, he does have giant cell arteritis. And if you look, out in the periphery here, you can see the same kind of classic tapered narrowing lesions here that we see with temporal, or as it's otherwise known, giant cell arteritis. And indeed, one of the most feared consequences of this disease is sudden blindness. So, if you suspect you have something like this, always treat it immediately with steroids and kind of ask your questions later, work it up later. One of the unusual cousins of temporal arteritis, it's about 1/4 as common in this country as giant cell or temporal arteritis, is this condition, which kind of looks similar. It's affecting, in this case, a 20-year-old woman who has no peripheral pulses. And I'm sure you've figured out from looking at, pictures like this or down here in her aorta where she's got scattered lesions that she's got Takayasu arteritis, one of the close cousins. And then we've got, a variety of other vasculitides that we see even less commonly than the giant cell ones. This vasculitis here, which can affect medium-sized mesenteric vessels or even the smaller mesenteric vessels and produce damage and aneurysm formation, is polyarteritis nodosa. Again, fairly uncommon kind of disease. Well, here's a 25-year-old man who died with some exertional chest pains. If you look carefully at the autopsy here, you'll notice. Yep. Can you hear me? I just had somebody leap in there. If you look at these, you'll see that he's got some coronary aneurysms bulging here, and when you ask what the disease entity is, in this case it's Kawasaki's disease. It's always fun to be face-to-face, because when people will inevitably say, why would you name a disease like this after a motorcycle? And of course the answer is because there's hardly any cases of this. But see, they're rare diseases. You see what I did there? Anyway, moving on. We've got some other things that it's not always clear whether they're vasculitic or not. Here's a person who's got ischemia of both upper extremities, and it's actually causing diffuse digital infarction. That's what the angiogram looks like. You'll see a bunch of little acute scattered cutoffs and corkscrew lesions. What would you say if I told you that this was a disease that was caused by camels? Well, the thing is, it's caused by camels, but not these kind of camels. It's caused by these kind of camels. This is what we call Berger's disease or thromboangiitis obliterans. And, I told you that it's not totally clear whether this is a vasculitis. Almost all vasculitises show signs of systemic inflammation. You'll see high SED rates, high CRPs. With thromboangiitis obliterans or Berger's disease, the SED rate is typically low, often 0 or 1. And in fact, that's one of the better ways of getting an idea that that's what you're dealing with. So keep that in mind. This entity has a paradoxically low SED rate. Well, here's another one of these funny kind of vasculitic things that just kind of defy description. 29-year-old man here, or I should say defy good categorization. He's got a history of uveitis and some small genital and oral ulcers, and this man presents with a spontaneous DVT. Well, not the strangest thing in the world. Yeah, very good, Christian. So we do a venogram. There's his DVT there in the femoral area, but in working him up, he's noted to have an abdominal aortic aneurysm, and on further evaluation, he's got these small renal aneurysms. Well, come on, kids. How many things will give you an abdominal aortic aneurysm and renal small or medium vessel aneurysms and DVT? I mean, that is, an unprecedented combination. There really is only one disease entity that affects all these things, and that is, as Christian said, Behçet's here. So, very good. Feel free to, continue leaping in here. Well, it looks like we're back to our syphilitic aneurysm again, doesn't it? Except this ain't a syphilitic aneurysm here. This is an aneurysm that might have been found in a particular pharaoh named Akhenaten. Akhenaten, although he was a pharaoh, a man, was always pictured with this weird kind of long neck and long extremities and gynoid habitus. He's the only one of the pharaohs to ever look this way. We have, of course, I got to black out his eyes here so you can't recognize this person, but, we've had at least one American president who's been suspected of having something along the orders of this. And this is, of course, Marfan syndrome, which can produce aneurysms of the ascending aorta. All right, well, here's this takes kind of a rocket scientist to look at this. If you can figure out what this is, you're done and you can get on with figuring out how to treat it. But why does this person, this young man, he's 30, have this small aorta and these small iliac arteries, and why does he claudicate? And I'll give you a clue. His problem and Godzilla have something in common. Any idea what that might be? Godzilla and these small vessels. Well, the answer is they're both caused by too much radiation. In this case, there you go, radiation arteritis. Excellent, Heath. if you guys want to weigh in on some of these or try to guess, I can certainly slow down and give you a chance to type in if you're interested. We'll see who gets it. But yeah, Heath just got it here. This is radiation arteritis, and of course, once you know what it is, you know what you're up against, and you've got some ideas then about how you're going to treat it. Well, this is one of my. That's what we'll do. You guys just. Gregory just suggested, offer up the answers here as you think them, and I'll give credit to, whoever it is that scores first. I don't know if everybody, sees what everybody else writes in, but certainly I do. So, all right, well, here's a young girl. It's, way to go, Heath. Heath says it's Ehlers-Danlos type 4. This is and so does Rivera. This is a young girl. I love this picture because it always looks like her head's on backwards. But what she's trying to show me is that she can basically hyperextend and hyperflex her shoulders. And when you turn her around this way, you notice she's got this god-awful, gigantic midline incision. Now, what on earth is a young girl like this doing with a huge midline incision healing up like that? The answer is she had a big dissection. She dissected her aortoiliac region, nearly died, had to have this repaired, unfortunately, by an open surgical procedure. But, of course, the big question becomes immediately why? Why would this happen? And the answer is Ehlers-Danlos. Typically a type 4. There's some other types that this could be. In this particular case, I can't tell you exactly which type she had, but statistically, 4 would be the most likely. Okay, you rocket scientists, what's this? You guys ought to recognize this. This is a triad here. We've got port wine staining. Yes, Heath wins. KTW. This is Klippel Trowny. I saw a case of this today. In fact, referred in. It's rare, but not ridiculously rare. This particular case has the port wine staining that you see. It's got the varicose veins, but they tend to be a very atypical type of varicose vein when you see them. This is the variant you always worry about, sort of a retained sciatic vein, which often the patient will come to you and want this weird lateral varicosity removed. Well, don't do it because typically these patients have underdeveloped conventional deep venous systems. They may have absent popliteal veins, for example, and this is their main source of venous return. So you'll be very unhappy. You'll have a very unhappy patient if you try fixing that. And hemihypertrophy is also a part of this syndrome. There's another, typical example where you'll see, underneath this port wine stained area, this hemihypertrophic limb. So that constellation of port wine staining, atypical varicose veins, and limb hemihypertrophy is classic for KTW. Okay, well, this patient comes into my office and says, "Doctor, I'm here because I've got these extremely prominent varicose veins on the back of my hand, and I'd like something done about them." I ask him, what's going on with your finger? He says, forget that. That's just, I slammed it in the car door, when I was a kid, and it for whatever reason, it's never healed up all the way. Sure, he says high flow AVM. Here's another man with the exact same gigantic varicose veins and sort of a very similar looking thumb when you roll them around there. And when you do the angiogram, you've got it. This is a high flow AVM, and it's amazing how often the patients will come and ask, they'll present not because of the arterial manifestations or the sore finger. They've learned to live with that. They come in when they start to notice these prominent, sometimes pulsating or buzzing veins. That's what really upsets them and brings them in to see you. You wouldn't miss this clinically, but it is an uncommon enough entity. Okay, well, rocket scientists here. Let's see which. I'm already getting a flavor for which one of you guys can type the fastest and think the clearest. 40-year-old with calf claudication, and this is what his leg looks like on angiogram. What's he got? Can't give you much more history than that. Popliteal entrapment system we've got a an answer of gastroc entrapment would be great. Would be a great diagnosis. What if I tell you that this guy's in a neutral position right now? He's just laying down and his leg is completely relaxed. Would that change anything? What's causing this big filling defect here? Heath says, yes, that would change something. Scimitar sign. Ooh, so lecture one. Greg, Joji says cyst. Well, adventitial cystic disease. You guys think you're so clever. Well, let's open them up here and take a look. And it's not cystic disease. See that? It's a big aneurysm there. You guys got a popliteal aneurysm. So we cut it open and, hey, wait a minute here. I cut this aneurysm open to try to fix it, and I'm getting all this clear mucinous stuff. In fact, there's what it looks like after I've extracted it from this lesion right here. Yeah, you guys are right. This is a popliteal cyst, cystic adventitial disease. Pretty uncommon cause of claudication, although if you were to look at non-atherosclerotic 40-year-olds with calf claudication, it's probably up there as far as the things that you're going to see. Awesome images, says Heath. Yeah, that's what you pay me the big bucks here for. Okay, well, this man comes into my office, and he's, for the last 3 months, has been developing these little sores on the ball of his foot here, and you can see up here around the ankle, he's got some lesions. He's got these over here. They're tender, and they're growing. I mean, you didn't have them 3 months ago, and they're bigger now than they were a week ago. Any thoughts about what these might represent? Bacillary angiomatosis or Kaposi's disease. Boy, you guys are tough. Yeah. Here's another example of this in the arm, and here's another one downstream. These are, in fact, angiosarcomas, of which Kaposi's is by far the most common, because of its relation with AIDS and because of the non-AIDS variety that we see in elderly folks. But you really got to be concerned about this tumor. If you were going to sign up to have a tumor, this might be one of the 3 or 4 things that you would least like to have. And it's almost impossible to salvage these limbs, when you see them at this stage. Even amputation, by the time you see these lesions, they've typically metastasized enough that you're going to lose the patient no matter what you do. So this is an absolutely horrible kind of a lesion to have. But it reminds us that we can have malignant vascular diseases. And when again, if you can figure out what it is, that'll dictate then how you're going to treat it. Okay, anybody recognize, let's see how brilliant you young kids are. Anybody recognize this collection of dudes here? They were English musicians from the 1970s. They were the first band signed by EMI Records. That was the Beatles label, and they were going to actually be the next big Beatles. They had about 5 or 6 big songs in the United States. You recognize these handsome blokes? Yep, I'm getting a lot of silence here. This is the problem with you kids today. No sense of history. This is a band called Badfinger, and they were, in fact, destined to be huge, except they weren't that good. But it reminds me that I like to just kind of mention a little series of cases here about, about bad fingers here. The first case I'm going to give you is a 68-year-old man who has the subacute onset of painful, dark fingertips. Eventually, his skin breaks down, and I tell my residents and med students when I see them, when you got hand problems, you got to look at the palms. That's the big thing to always remember to do. So when you flip his hand over and you look at his palms, he certainly kind of resembles that fella I showed you earlier with the Berger's disease. But this is a little different. This man's not a smoker. He's been otherwise healthy. Hypothenar hammer syndrome has been offered. That would be possible, although you don't see those lesions bilaterally. It'd be very unusual to have a bilateral symptomatic hypothenar hammer, but also, the thumb and first finger involvement is a little atypical. You think of more of an ulnar distribution. So I'll give you another clue here. He's also got the same kind of lesions developing on his ear. Now, what do the fingertips and the ears have in common that might give you a little suggestion about what's going on here? Can you think of some property they share, something that... Ergo would be very good. This could be a vasoconstrictive thing. In this case, though, typically internal organs, you may get angina, you may get other problems with ergo. This is something that just seems to be affecting the periphery, the areas that are, most exposed to cold. Leprosy, frostbite, these are and Dhruv Patel has come up with a suggestion of cryoglobulinemia, and in fact, that's what the workup in this particular case shows us. This guy has cryoglobulinemia with abnormal circulating proteins, and they trigger the clotting and inflammation that he gets. This is a textbook example of what you'd see with cryoglobulins. So, very good job. Oh, you guys are, thank God I have a job when I got one, because I'd hate to compete against you. All right, Badfinger's number 2 here. 63-year-old woman. Her fingers and hands turn white in the cold. She's developed these sores on her fingers and her ankles, and she's got some subcutaneous calcium deposits. Let's look at the palms, okay? And here's what her hand looks like in her palms. You can't see them very well on this picture, so I'll just highlight here that she's got these little blanchable red telangiectatic lesions located all over her hands here. And in fact, that's what her ulceration on her ankle looks like. There's one of her subcutaneous calcium deposits here. And this is what her, this is what her face looks like with those same little lesions. And we've just had a suggestion of crest come in, and that's exactly what this is. This is scleroderma with the crest manifestations. Probably one of the more common of the uncommon things that you'll see affect upper extremity digits. And in our vascular laboratory here at Mayo, we probably diagnose about 30 to 50 patients a year with Crest syndrome who are referred over because they have atypical Raynaud's, and you examine them and as part of the study, and you can't help but make the diagnosis. Third case here, 32-year-old female. She has a cold, painful left arm and shoulder, and she's got a fingertip ulcer. There's her fingertip ulcer there, and you notice her entire left hand's a little painful. Well, you remember what we're supposed to do at this point? What do I tell the residents, the medical students, when you got a hand lesion like this? You got to look at the palms. So we flip her hand. Oh, my God, in this particular case, this is the palm that we're looking at. What kind of sick joke is Rooke making right now? Well, this is a little bit of a sick joke, actually. When you take her history and you ask her about this palm tree tattoo she's got on her ankle, it turns out that she got this about a year ago when her dermatologist took a big, ugly black mole off her leg and left a large scar. She decided to get this tattoo put on to cover it. As you can deduce, this was a melanoma. She now has metastatic malignant melanoma and the subsequent cancer-associated paraneoplastic problems that go along with it. Remember that many types of cancer will give you these paraneoplastic pictures in which your patients will have vasculitis, clotting abnormalities. That's what's happened with her. She's got inflamed blood vessels, but more importantly, she's clotted off the blood vessels to her left arm up in the axillary region. All right, well, those are the common presentation of uncommon diseases. Let's move ahead here a bit and look at the common presentations of uncommon diseases here. And it looks like I'm really right on time schedule-wise here. The uncommon presentations of common diseases are a little less common. They're probably 5% of a practice like mine. And the big question here is not what are they. You'll all know what these things are. The question is going to be, what do I do about it? Now, I give you an example. Here's a perfect example. You know what this is. I don't have to explain to you what's going on here, but what do you do about it? Does this need treatment? How are you going to treat it? How important is it? How aggressive is it? These are the kind of questions that inevitably come up with these kind of problems, and they're not easy to answer. You know what it is. The question is, what are you going to do about this? Good example here, patient with a massive DVT. In fact, this DVT is so massive that the blood can't flow out of the leg, and as a result, this person can't get blood into their leg. They actually have are developing leg ischemia, not on the basis of impaired arterial inflow, but because they can't get blood flow out. Does anybody remember what we call that condition? There's a name for yes. Well, we have PCD, and I think what Heath is saying is phlegmasia ceruleus dolens. Yes, perfect, and you guys all have it. So how are you going to treat this thing? Interventional radiologist? Well, you guys know how to lyse clots. So you get in there, and you pass a catheter in, maybe even give something systemically. The problem is, with these high compartment syndromes and often the ischemia that's associated, you can wind up with a giant mess. You know what the problem is. The issue is, what are you going to do about it to try to save this guy's limb? And in this particular case, they wound up with doing the only thing they could do, trying to lyse it, which in this case did lead to bleeding, and they wound up having to do compartment releases here. It's an awful mess, but it's typical of the kind of problem you run into. Here's a man who stepped on a nail as a kid and now has this venous aneurysm that's formed where the nail came out through the top of his foot. You see traumatic aneurysms like this in the arterial side all the time. You can see them on the venous side. Nothing special. What do you do about it, though? Does this need treatment? You might say, well, maybe, maybe not. It's a little bit elective. How bad can this be? You'd be right. But let me show you this interesting case. I had a patient who was in a car accident 4 years ago. They were wearing their lap belt. They survived. Everything seemed to be fine at the time of the accident. They've now developed some pain that turned out to be a bad gallbladder. But in the process of working up their gallbladder, they got a CT scan which led to these venograms. And right here where the lap belt comes across, we've got a big kind of a false aneurysm here where this was disrupted. And right where the chest belt comes across, we've got another one. All right, rocket scientists, so what do you do with this in the era of evidence-based medicine? You're 4 years out, you get the gallbladder out, and the patient now reverts back to asymptomatic status. Do these lesions need to be treated? Do we fix them openly? Do we stent the veins here? The answer is neither me nor you nor anybody else knows exactly what to do in a situation like this. The problem is not identifying what's happened here. The problem is we don't have a database that lets us go back and say what we ought to do to an asymptomatic patient with these lesions. We actually, one of our surgeons went and openly repaired these two, but highly controversial. Well, here's an easy one. Guy puts his hands up in the air and the hands turn white. I know what this is. In fact, since you're radiologists and you like to look at radiology things here, he's got that big cervical rib there. So what do we call this condition that this guy's got? There we go. Well, we've got a issue of Paget-Schroeder. Absolutely. And we've got thoracic outlet. And they're both correct. Generically this is a thoracic outlet positional obstruction, thoracic outlet syndrome, but probably the most common manifestation of it is the Paget-Schroeder variant where you wind up with venous occlusion. That's what's happened over here. And as a result, with chronic venous occlusion, you can get collateralization and development of veins like this. Well, that's not too rare, you say. But, one of the interesting things here is just how when you think you've sorted the world out, it tends to be more complicated. Here is my nurse. This is my nurse who I've worked with for 20 years. She bends over one morning on her way to work at home to pick up her cup of coffee, and she feels something snap in her shoulder, she says. And it's so painful it drops her to her knees, brings tears to her eyes. By the time she gets to work, she's developing these prominent collateral veins over her chest wall. So we didn't even do an ultrasound. I mean, come on. I'm a clinician. There's nothing else this can be but Paget Schroeder. She must have done something to occlude her axillary vein. So we send her right up to venogram, and sure enough, there she is. You can see that the vein is occluded there, so we get the TPA out. We're getting the catheters ready. We're going to push this in there and try to lyse this clot. And one of the technologists moves her arm, and holy cow, the thing opens right up. This was not clotted. It was positionally occluded. Well, how on earth is something like that going to happen? The answer is found on just this plain old X-ray film here. If I show you this area and enlarge it a little bit, you can see that her first rib has actually fractured, and it's displaced, and it's pushing up against her vein, so that she's developed kind of instantaneous, immediate thoracic outlet syndrome on the basis of having a fractured, displaced rib. So we took her right to surgery. Within an hour, she went up to surgery. Here she is right before she goes, and here she is an hour after she comes back from a first rib resection. And you can see already we've decompressed her veins enough that the superficial pattern has now disappeared. Interesting case. Well, other kind of rare presentations of common things. You could hardly get anything more common than this right here. That's a garden variety DVT, and I still like to show venograms whenever we can because they're just so, we don't see them so much, and they're so cool looking here. You know how we would treat something like this. Actually, a DVT like this, we would treat nowadays with heparin, anticoagulants, put them on Coumadin for variable periods of time. In this particular case, they thought, we'll just start Coumadin. So they just Coumadinized her. She didn't want to come in and get started on heparin. And 4 days later, this is what she looks like. Anybody recognize this entity? And we've got Coumadin necrosis. You bet, Heath. Yeah. Usually seen actually in the setting of people with some kind of underlying, very good protein CRS deficiency. Usually, they almost always have some type of underlying thrombophilia. But if your patient has never been anticoagulated before, you should always try to start them on with heparin first and then switch them to Coumadin on the outside chance that they could develop something like this, which typically affects the fatty tissues and can be just a horrible mess to try to treat. Now, this raises this whole issue of things that we know what they are, but what do we do about them that fall into this category of medical complications? And you folks are all going to be encountering, for example, this dilemma. You've all gotten your venous ablation devices, either the radio frequency devices that you can run up there, or maybe the laser devices like these, which can be used to ablate veins. The point is that every once in a while, due to lack of adequate tumescence or a vein that's just too close to the surface, or perhaps just the category that stuff like this happens, you will develop burns like these. I can blow that up a little bit here. You know, talk about an interesting dilemma. As physicians, we've dealt with burns forever, but think about this. How often do we deal with burns that occur from the inside out? That's sort of the ultimate of iatrogenic problems right there. People in nature just don't tend to burn themselves on the inside through to the outside of their skin. And how we deal with these, how they heal, we're still learning. Let's hope none of you guys have to learn too much about how we do this. Another kind of an iatrogenic complication that we see comes from our vein grafts. In a perfect world, it always looks, our dialysis fistulas and things always look perfect. In the real world, we wind up with these difficult situations where, yes, we know what this is, but exactly what do you want to do about it and how do you want to handle it? Problems like this are going to be some of the more difficult things that you guys are going to be facing in your careers here. I'll give you a really odd case here. I got odd cases nobody else ever sees. Here's a 72-year-old man who has a 3-week history of very intense whole body itching and some mild dermatitis. There's his lesions right there. He comes and sees a dermatologist, and he's itching so badly that they say, we're going to put you in the hospital and try to control this. So they put him in the hospital and put him in wet dressings, and they're going to do skin biopsies and allergy testing and stuff. Well, on the second hospital day, not the patient, but the patient's roommate. This is a double room with 2 patients in it. The patient's roommate awakens with this painful swollen leg. So naturally, the hospital team says, let's send him downstairs and get a duplex scan and look for a blood clot because, that's a common cause here. Now, at this point, a mix-up occurs. The patient with the rash, the patient with the dermatitis, not the patient with the swollen leg, gets loaded onto the cart and taken down to the ultrasound. This is the result of our, crack interns or our crack orderlies that come and pick them up. Now, you would think the patient would object and say, hey, my leg's fine. I'm here with the rash. How about my roommate here with the big swollen leg? But, in fact, here in Minnesota, we have this entity we call Minnesota Nice. People don't like to complain. They take the approach that, well, you're the doctor. You know what's best. So we wind up with this sentinel event, basically. We send the wrong patient down to get the ultrasound. The guy with the swollen leg is left laying in the room, and the guy with the skin rash goes down for the ultrasound. Now, the problem is about 15 minutes later, I get a call from the ultrasound area telling me, hey, your guy's got a giant clot in his leg here. So think about this. This guy turned out to asymptomatically have a giant clot. What would you think of with this guy who's got a new onset diffuse rash over his body and now has an acute DVT in his leg? What do you think I ought to be thinking about? Somebody suggested anthrax? Well, probably not. There's something else that would just be a lot more common, sort of a generic category of things that you'd want to tackle in this setting. Diet? Well, not really. Vitamin K? No, that would. This is a case here of somebody who's almost certainly got a malignancy. This is a paraneoplastic problem where the patient has got cutaneous rash and cutaneous vasculitic type problems along with a clotting abnormality. So as part of his workup the first day, he got a CT scan and a colonoscopy, and sure enough, there on the colonoscopy, kind of the mother of all gigantic tumors. So what do we do about this? We treat his cancer, and he's going to get better now. All right, well, that leads to another category that we have of diseases like this, the vascular look-alikes. These are my 3 kids. God, they start out, let me just warn you guys that have them, they start out cute like this, but by the time they're teenagers, you just want to hang them all here. The vascular look-alikes include, for example, a big variety of ulcers on the foot. Usually you can tell ulcers just by looking at them. This is a This is an ischemic ulcer caused by arterial lesions. Here's a venous ulcer, and you wouldn't miss this venous ulcer. You know, it's very easy to identify. It's got hemosiderin, red beefy skin changes there. It's on the medial malleolus. What kind of ulcer is this? What's this patient got? It's painless. It's located over a pressure point, and Patel says it's diabetic. You're correct. Here's a more atypical ulcer. Yes, neuropathic. That would be right for that one. Here's one that's very painful. This patient actually levitates if you look at these ulcers. And they're down around the malleolar area, so it was referred over to us with the idea that this was most likely some kind of venous ulcer, but they're far too painful. This patient doesn't have any venous disease. Their veins are normal. These are Pyoderma Gangrenosum. I like that as a thought. These are actually vasculitic ulcers, more of the cutaneous PAN type lesion here that you can see. So these are painful vasculitic ulcers. We see them in hypertension. In this case, cutaneous PAN caused or seen in association with hepatitis. Hepatitis B and C are frequently associated with PAN. Here's a lesion that was sent over with the thought that it must be a venous lesion, but it's actually an infection. This is a Blastomycosis Fungal lesion here. All right, now this has to be a venous ulcer, right? It's on the medial malleolus. It's got hyperpigmentation. It's, I mean, what else could it be? Except that what if I tell you that I study this patient's veins, and this patient's veins are completely normal. They're not incompetent. They're not obstructed. And indeed, it turns out this patient has no venous disease at all. Well, the way you make this diagnosis is you listen to the patient's history. The patient says, you know, doc, I was doing perfectly fine until 3 months ago when I woke up with a terrible pain in my ankle, and I looked down, and there was a spider biting me right at that spot. I swatted him. Well, this is a brown recluse spider bite. And I don't know where you guys are all located right now, but here in Minnesota, we got brown recluse spiders in the summer, and we will see these on occasion. And this one only looks like a venous ulcer because it happened to be bitten right in the exact area where a venous ulcer would occur. This ulcer here was also sent over as a venous ulcer because it's down on the ankle. It's actually the reason why we remove those stupid little basal cell and squamous cell cancers, not because they're going to metastasize and kill us, but because when they spread locally, they produce ulcers like this. This is a cancer gone bad, one of the skin cancers gone bad. All right, now here's a really odd ulcer. It's got this infected exudate here. It's got this serosanguinous fluid, and when you, okay, see this, you know, this is the problem even with webinars, is that sometimes you just get screwed up here and you put in, you know, the wrong slide. Forget it. This is not an ulcer. This is actually something unrelated. But this is an ulcer. This is a good ulcer here. This is a 36-year-old truck driver. And are you ready for this? 3 years ago, while on the job, he was involved in what seemed at the time like a relatively minor fender bender. And yet, immediately afterwards, his right leg began to swell. He's developed these sores, and for the last 3 years, he has been unable to work because of this on-the-job injury. So his employers who've got him on workman's comp have been sending him around the country to various doctors trying to figure out what the heck happened so they can get him back to work. Well, you're looking at the same thing I am here. Anybody know what's causing this? Can you look at this and see what the problem is? I'll give you a hint. I can't. I don't have a clue what this thing is looking at that particular lesion. Well, I don't have a clue when I look at this lesion, but suppose I were to step back here just a bit and look at it. All of a sudden, I got a clue. What you see there up above is a tourniquet lesion. Every time somebody turns their back or this man is alone, he takes off his belt or his pillowcase or a towel. Yes, this is a form of lymphedema, but it's being caused iatrogenically. He's doing this himself by putting a tourniquet around his leg and cutting off lymphatic and venous return. So this is a Munchausen type problem here. The answer to curing this thing, what are you going to do about it? Yeah, there you go, skin popping. You need to send this guy for a psychiatric consult here. Oh, God. And I forgot about this case. Guys, I sort of apologize for this. This is, to the extent any of you folks might be young fellows here, this is really scary. This is back when I was a resident. This was the infant son of one of my medicine residency classmates. This was their first child. They lived a few houses down from me here in Rochester, and Dad had never been left home alone with the baby before. His wife's mother got sick. She had to leave on short notice, so Dad had to stay home with the baby all by himself, and had never done it before. I get a call around 6 o'clock at night. Tom, get over here. I just took the kid's clothes off. I think he's occluded his vena cava. His legs are swollen and they've turned blue. So I come running over there. Now, you got to understand, we're all scared. We're all beginners here, and yet armed with nothing but my superb clinical skills and a good history, I was able to discern the following: that Dad, being a first-time father, had washed the kids' new blue jeans and put them on while they were still wet. So you think about it. Over the course of the day, two things happen. One is they dry, they shrink, so they were a lot tighter when he took them off than they were when he put them on. He figured the kid's leg had swollen. And, of course, the other thing is the dye came out and turned them blue. So, this is a case of pseudo-venous disease here. But it does serve as kind of a good reminder to everybody. And my wife has collected a bunch of pictures of these as to why, Dad should not be left home alone with infant kids, because we are a little bit prone to not paying as much attention as we ought to. The only one of these that I was actually responsible for was this one here, and I take responsibility. All right, well, give you a few more presentations here. Always be concerned when the guy giving you a presentation says that this case involves poor hygiene. All right, that's something for you to worry about right there. This is a 56-year-old man with poor hygiene, and he comes in to one of our outlying practices with a severe case of venous insufficiency, and he's got an ulcer on his ankle as well as a painful great toe. That's what his ankle looks like. Looks to me like a pretty straightforward venous lesion, and that's what his painful big toe looks like. So the doctors at this practice about 50 miles from Rochester say, we're going to put an Una boot on you. I don't know if you know what that is. It's kind of a paste wrap device here. They put this Una boot on him, and they tell him, you get yourself in to see the folks over at Mayo as quickly as you can here, and let them take care of you. Well, hang on one second here. He comes in to see us after a week, and he's got this Una boot on. So we take the Una boot off, and as we take it off, we can see that there are things moving under the skin. This guy actually has maggots that have developed under there. Now, I know what you're thinking. That's gross, disgusting. Gross is in the eye of the beholder. I got this deer head downstairs, and my wife says that's gross, but, I don't think that's gross at all. This is beautiful. It's nature. Looks magnificent. Now, I will tell you that what's disgusting is this, because I cannot understand what kind of a person in their right mind shoots a deer that's out having a good time at a party. That's just sick. All right. A common problem with an uncommon presentation here, trauma to the leg. And I'll just kind of leave this as the last one in this category here. I've got a 70-year-old guy that I've followed for years because of his arterial disease. You can see here his tibial vessels are calcified, and I've always told him, look, you got compromised blood flow to your legs. Whatever you do, protect your legs at all costs. Well, I hadn't seen him for a long time. He comes back to see me, and he's got these screws at his ankle. And I said, I told you, you might not heal your legs if you injure them. How'd you do that? He says, Doc, that's an interesting story. Now, he's been married to this woman for almost 50 years, and she's kind of got this B-52's hairdo thing going on. Her mom had told her that, when your man comes home from work, you got to get gussied up for him every night. So, sure enough, right before he comes home from his job every day, she has this little ritual where she runs upstairs to the bathroom and sprays her hair. On this particular day, the nozzle to the hairspray can jams, and it's spraying all over the bedroom. So kind of smartly, she goes over to the toilet, lifts up the lid, and empties the can into the toilet. She puts the lid down when she's done, and because she can hear the guy coming home. Now, it turns out that he's also got a little ritual that he does every day when he gets home. And, if you think about it, you can't develop vascular disease like this unless you're a smoker. So he goes upstairs to the can, sits down on it to do his thing. He's smoking a cigarette, and he says to me, Doc, the last thing I really remember clearly, I took that cigarette and I dropped it between my legs into the toilet, where all of this hairspray is sitting in a layer on the water. Kaboom! This guy is blown off the toilet seat, okay? He's got these burns all over. His wife can hear him upstairs, crashing around. She comes running up the stairs. She sees smoke. She hears screams. She calls the ambulance. The ambulance guys come and get him. They go up the stairs with a little, stretcher. They load him on. They're bringing him down the stairs. And the guy in front here asks, how'd you do this? And he tells them, well, this guy in the front starts to laugh so hard that he drops the stretcher. That's how the guy breaks his leg. True story. All right. For our last couple of minutes here, we'll just go over a couple of cases that are the hardest of all, the uncommon presentations of uncommon diseases. These are less than 1% of your cases, and you don't know what it is or what you're going to do about it. They're both hard to figure out. Here's a guy that goes in to see his doctor about 50 miles from here because he's got a red eye. The doc looks at him and says, well, your problem, buddy, is you got a red eye. So he says, we're going to give you these steroid drops, and I want you to come back in a week. You'll be better. Guy comes back in a week, and he's not better. Now he's got these lesions. The guy says, doctor says, you've got zoster. That's what this is. This is shingles. Says, I'm going to give you some shingle medication here. You're going to get better. Come back in a week. Guy comes back in a week. He is most definitely not better. Now, I don't know if anybody recognizes this. This is one of the rarest of cavernous sinus thrombosis. Very interesting idea. That's one of those mucormycosis type things. But that's not what this particular disease is. This is Wegener's granulomatosis, one of those Cianca vasculitides. And once you figure out what it is, if you're lucky, you give the patient immunosuppression, steroids, sometimes sulfa drugs, and they'll respond. This guy did, but even figuring out what it is no guarantee that you're going to save the guy. We already looked at a case of this today. Why am I showing you another one? Guy's got stretchy skin. He's got easy bruisability. He's got this abdominal aortic aneurysm. These are all consistent with Ehlers-Danlos. We talked about this right at the beginning. I'll just point out to you that Ehlers-Danlos also can affect the veins. This is one of 3 cases that I've seen of popliteal venous aneurysms associated with Ehlers-Danlos. Now, if you think that it's tough to know exactly what to do with the arteries, try figuring out how you're going to fix these venous aneurysms in a connective tissue disease where the arteries tend to fall apart and stretch and continue to degenerate no matter what you do. Another similar dilemma is shown here with this saccular aneurysm which you could see with a condition like tuberous sclerosis, where these little neural tumors go in and damage the aorta. But in this particular case, this is actually its cousin, neurofibromatosis, elephant man disease. And again, to show you how complex this can get, you're not going to believe this, but this is a patient with a large neck mass in the setting of neurofibromatosis. And what this neck mass is actually a gigantic, in this case an 11-centimeter jugular vein aneurysm. Now, what makes this absolutely incredible is that this is the second case of gigantic jugular venous aneurysm I have seen in people with type 1 neurofibromatosis. So there's something about this disease that has a little predilection to the jugular vein. But that is truly amazing. And maybe the rarest of all the venous diseases that you'll see, if not the rarest, it's got the coolest name, is this entity, where they've got these little rubbery lesions on the skin. There's some here over the back. You can see prominent irregular veins on the face, rubbery venous lesions on the lips, very prominent venous pattern everywhere with these little rubbery lesions. Nevus of Atta. Whoa! Well, maybe. Let's see. What else did we get here? We've got blue rubber nevus syndrome. Holy cow, you guys are, in fact, rocket scientists. The reason I was seeing this lady was she had this 4-centimeter popliteal vein aneurysm. And indeed, this is the blue rubber bleb nevi syndrome. This is the rubber bleb nevi. Any of you ever see a case of this in your life, you've been looking at patients too long. And just for a last case, just to remember that there's nothing that is too weird to think about here. This guy's got a garden variety varicocele, but he's really a little bit psychotic, and he's convinced himself that he has worms, night crawlers, in his scrotum. We do an ultrasound looking at things, and everything looks good down the testicle. You get up to where the varix is, and he's got a needle in there that he was trying to pin down some of these worms, and lost the sewing needle into the scrotum there. I thought that would just, as you guys start to think about taking your boards and studying for the perfect way to sort of end tonight's little soiree into things that, what are you going to, in this case, what is it, what are you going to do about it? So remember, we have these unusual vascular problems. We tell people when you hear hoofbeats, don't think of zebras, but in fact, sometimes they are zebras. They consist of common presentations of uncommon things, and the big question there is, what is this thing? You've got the uncommon presentations of common things, including the look-alikes and the complications. Those are, really issues of, I know what it is, but what am I going to do about it? And then this weird stuff that you may not know what it is, and you may not know what you're going to do about it. And folks, I'm going to end it right there. I was told to be done at 1:45, and I've got 8:39 here, so I think we're within our limit here. Okay, Heath. Well, I'm glad you like that. At this point, I don't know if I need to do anything else for you, or if I've talked a long time for you here. Glad you enjoyed it.
No questions came through, but definitely a wonderful lecture. Thank you very much.
Great. All right. Well, you guys, why don't you guys have a good night here?
You too.
And I'll disappear. Thank you. Good night, all.